but just in the interest of time, etc., and so we don't have folk feeling to drop off during the Q&A, we'll get ourselves picked up and starting. I think the numbers are still increasing slowly. So welcome everyone to today's Maurice Bloch lecture. Really glad that you're able to join us. Today I'm delighted to be able to welcome Dr. Jess Potter from London. Sarah MacDonald and I were delighted when Jess agreed and accepted the invitation to speak. I've known Jess for a good number of years now around her work in migration, and particularly in relation to asylum seekers and refugees. So Jess is a consultant in respiratory medicine and respiratory medicine research, and with a particular interest around TB. But a lot of her work has focused on issues of health and access to healthcare around for patients with TB, particularly those who are marginalised, so migrants, asylum seekers and refugees, and also their experience of healthcare. And that's particularly what she's going to talk about today. The other thing that Jess is really well known for is a real passionate advocacy role for migrants and for asylum seekers and refugees around, again, issues of entitlement and rights to healthcare. She's very active, for example, in the Patients Not Passports campaign. In fact, I think was probably co-founder of that campaign, and has done a lot of work in that area as well. So I think that kind of passion around ensuring rights and access for people to healthcare is also one of the other things that will come through very strongly today. So I'm really looking forward to it, and I'll hand over to Jess. If you have questions, if we go through, if you put them in the Q&A, and then we can start to pick it up at that at the end of the presentation. Okay, Jess, thank you.
Hi, good afternoon, everyone, and thank you so much for inviting me to talk today. I will carry on and not say anything about else. Kate said everything about me that you need to know, but I'm also on Twitter, and so my Twitter handle's there if you're interested. I mostly tweet about migration and healthcare access. So today I am going to talk a bit about what is healthcare access, how is it researched and conceptualized, and then focus on this concept of healthcare access called Candidacy, which was developed by Mary Dixon-Woods and colleagues, and ask what does it offer, and also talk you through some of the findings from my research which I use to extend the concept. So this is, as Kate said, I'm interested in TB, and I'm the clinical lead for the TB service at the North Middlesex Hospital, which is a DGH in North London. It's one of the ones areas outlined in amber in the picture, focus on London. You can see that TB in the UK is largely concentrated in cities, and in particular London. And I was working in East London in Newham around the height of the TB epidemic here in 2011. And the TB in the UK predominantly affects people who are not born here, migrants who move from a country where TB is common to the UK. Often I noticed at that time people were presenting late with significant illness, and sometimes people even died. And that led me to ask the question that Paul Farmer, the late anthropologist who sadly died earlier this year, why, if effective chemotherapy, so treatment, does TB remain a leading killer of young adults? I dared to suggest in one of my grant applications, of which I wrote many before getting my PhD grant, that TB was a social disease, and as such requires us to consider the social and economic factors that influence its spread, as much as we might consider the more traditional biomedical issues of vaccine and treatment development. Not a new concept, I hasten to add, and not particularly controversial in, I suspect, this room or this virtual room. But I was asked to remove that sentence as it was, quote, insulting to quantitative scientists. There are three central tenets to TB control: prevention, early detection, and effective treatment. And that's reflected in national strategies like the Collaborative Tuberculosis Strategy for England, where access to services is #1 on what we're trying to achieve, and also international strategies, for example, the WHO's campaign to leave no one behind, ensure everyone has good access to the care they need. But what is healthcare access? I quite like this definition from Levesque: the opportunity to have one's healthcare needs fulfilled. Healthcare access is a term often used in medical literature and yet rarely defined. It invokes a sense that entry into the healthcare system occurs at a single gate, a specifically situated point beyond which lies the health service, and an opportunity to determine the cause of whatever triggered an individual to present to the gate in the first place. But, and these are the maps of patients that I interviewed, accessing healthcare does not often happen at a single point in time or by crossing a single threshold. In addition, individuals may not only access what I would refer to as the formal healthcare arena, but may seek healthcare from friends, family, faith healers, alternative and non-biomedical sources. It is this complexity, that makes accessing healthcare difficult to understand and difficult to measure. One of the first models, first and most widely applied models of health-seeking behaviour came from the discipline of behavioural social psychology, the health belief model, which you can see on the screen here. It was first developed to actually evaluate why a TB screening programme in the USA was not effective. Both the health belief model and other social cognition models, for example, Fishbane's theory of reasoned action, which evolved to become Arjan's theory of planned behaviour, or TPB, centre on individual beliefs that actions have consequences, and these beliefs therefore affect behaviour. The health belief model in particular has been criticised for its dependence on rational decision making. See, for example, Pescalido in 1992, and its lack of acknowledgement of the influence of contextual factors. See, for example, Ogden 2003. If one considers healthcare access as a journey, then pathway models of health seeking and healthcare access seem more likely to be applicable. But in using the term pathway, I acknowledge that a well-trodden signposted route, which you might think of when you think of a pathway, comes to mind. And that is rarely the case in health-seeking trajectories. In 1968, Anderson first described a behavioural model of healthcare access which focused on individual level factors which affect utilisation. First described this, However, models of utilisation, and you get increasingly complex ones, for example, this one, which is a sequence-sensitive approach to modelling how people use health services, ignore those who do not access care at all. Highlighting the barriers which restrict access is another approach that can help highlight pathways to health outcome disparities, as with this model. However, a focus on barriers and facilitators ignores the constant negotiation between motivating factors or triggers and the often highly contextualized way these play out. And you often see in papers barriers and facilitators represented very simply in boxes, and that can be useful, so it's not to say that it can't, but I think that it does obscure some of the complexity. I quite like this model of pathways to treatment that was developed by Walter and colleagues. They updated this model of total patient delay, introducing the model of pathway to treatment. And it's akin to changing theoretical perspectives within health behaviour and social epidemiology. It adds an ecological perspective. So if you're thinking about ecological perspectives, then Nancy Krieger's work is the thing that really comes to mind. And that introduces the opportunity to consider the complex and dynamic interactions between individual biopsychosocial factors and wider societal, political and structural forces. Furthermore, it allows for multiple points of entry into the model, relevant because diagnosis of active TB may be made incidentally as part of screening for latent TB infection. And also, it allows for recurrent entries at the same point, an issue which exacerbates diagnostic delay in the diagnosis of TB, where a patient might, for example, present multiple times to A&E or to their GP. This model also brings in disease factors, so such as site size growth rate is listed in the picture. I'm going to come back to that in more detail later when we talk about candidacy. Also increasingly recognised in health-seeking behaviour is the importance of interpersonal relationships, social networks and community support. And I'll talk about that under the broad remit of social capital later. What this model perhaps lacks, though, is a detailed focus on the attributes of health systems. So Levesque, I turned to for a definition of healthcare access as the opportunity to have one's health needs fulfilled. And he describes this as an interaction between the patient and their abilities to access care, and the provider and the accessibility of the provider. And then he details this in a little bit, goes into a bit more detail with 5 dimensions of accessibility along the top row and 5 dimensions of ability along the bottom row. So we've now moved, going through all of these models, from measures of service use separate from exploration of individual behaviour to a more social, interactive understanding of healthcare access. Mary Dixon-Woods and colleagues' synthetic construct candidacy has become a well-established theory of informing the study of healthcare access. Using a method of critical interpretive synthesis, whereby research is drawn together and interpreted inductively rather than simply summarised or pooled, Dixon-Woods and colleagues systematically evaluated the literature on health service accessibility for vulnerable groups. And from that, they developed the Candidacy Framework to describe their findings. So I'm going to just read this out. Candidacy describes the ways in which people's eligibility for medical attention and intervention is jointly negotiated between individuals and health services. Candidacy is a dynamic and contingent process, constantly being defined and redefined through interactions between individuals and professionals, and managed in the context of operating conditions, including the biography of the relationship between patients and staff, the typifications staff use in categorizing people and diseases, availability of resources, local pressures, and policy imperatives. So I'm going to go back and highlight some of my issues, but I said to you before about health services and this idea of the formal healthcare arena, and that perhaps obscures the broadness of where people go to seek help. In its original definition, health services were used to describe who or what the candidate for care interacts with, and it seems at odds with the subsequent emphasis on social interaction. It conjures visions of hospitals, ambulances, clinics, and this material world that obscures the people who shape it. And then the term jointly, to refer to the way candidacy is negotiated, I think obscures the potential role of power within these interactions. Any good theory needs to be tested among different populations in different settings, and candidacy has actually been used pretty extensively in the literature to look at healthcare access for a number of different groups. To try and illustrate what it looks like, and I guess make it a bit more sequential, this illustration shows yet another pathway. Although Dixon-Woods and colleagues were quite explicit that candidacy was dynamic and constantly being defined and redefined. And you can see how we go from identification of one's candidacy for healthcare, navigate services, how permeable the services are. You then have to turn up to the services and say, hi, I need help. I'm someone you should be caring for. And then health professionals need to say, yes, okay, I accept that. And then they give you an offer of treatment and you may say yes or no. And all of this is shaped by operating conditions. So I've kind of reimagined this here with permeability of services as your membrane, navigation, asserting yourself for candidacy, identifying your own candidacy, adjudication, and offers and resistance to services. And all of this happens under these operating conditions. So I'm just going to go through the literature and also my data and talk to you a little bit about how I think candidacy needs to evolve. So my research looked at how people with TB accessed healthcare when they became unwell in the UK. And I was particularly interested in people who had recently moved to the UK, so within the last 5 years, and their experiences. Today I'm mostly drawing from data that came from biographical narrative interviews conducted with this group of people, but I also, and interviews with health professionals, including clerical staff, policymakers, doctors, nurses, who formed part of the patient's pathway to treatment. And there was also, I also collected structured interviews with 100 people who fit the inclusion criteria and were sequentially recruited. So the first thing I want to highlight is that in the Candidacy Framework, there is, there is this concept that newness is an issue in relation to an aspect of ethnicity. So the quote in the candidacy article is, recency of migration or newness should be distinguished from other aspects of ethnicity and may represent a particularly powerful form of deterrent help seeking. Now, whilst being a recent migrant certainly has an impact on how you seek healthcare, your knowledge, for example, of health systems might be different. Your mastery of the English language might be different. I really object here to the idea that it is an aspect of ethnicity. I think that this is essentially draws ideas of the racialized other. So that ethnicity must mean that you are non-UK born, and that for me is not right and needs to be corrected. So going back to this diagram that Mackenzie and colleagues illustrated before, I wanted to represent the work required to becoming a candidate for TB. And I've done this through a sloping trek to treatment upwards. I've used triangles here as pivots to draw attention to the additional conditions and resources that alter the balance, helping or hindering people moving across and between aspects of candidacy. And I pay attention to recursivity and the dynamism inherent in this process through the presentation of multiple overlapping diagrams. Recursivity meaning people coming back and to various different points in their healthcare seeking process, and that being affected by what went before. Inevitably, this is an impoverished model of reality, but I think it goes some way to distilling the salient features of candidacy as a conceptual framework. My findings show that the identification of candidacy consists of a shift from normal experiences to those that are not normal. And I'm using quotes here from my participants. In the context of TB, this shift is insidious, and this insidiousness permeates participants' entire health-seeking journey. Sensations are often explained away as normal in the context of an individual's understanding of their own culturally situated body. Many participants only recognize the beginning of their illness in retrospect, validating their experiences after the fact, further underlining this insidious onset. And for sensations dealt with in isolation, either by the patient or by health professionals, their place within a wider picture or jigsaw remained undefined until other pieces of the puzzle were made visible. And once abnormality was acknowledged, a tipping point emerged that prompted action. And this tipping point was unique to each patient and dependent upon material, social, and epistemic resources. This is a quote. I said, "You said that you weren't hungry." I think that, I'm not sure when, but I think that something between end of February, March, I'm pretty sure all the March, yeah, maybe end of February, I don't feel hungry. I couldn't eat. I just eat a little. And that's very unusual for me because I eat a lot, really a lot. Well, people from my country eat lots more than British. Our meals are very, very huge. Then I eat even more than them. I mean, normal people from my country, I eat a lot. But during that time, maybe I just have a sandwich, a small sandwich, and I still feel, oh, that's too much for me. So yeah, that's not normal. So normality for each participant was constructed within the meaning of normal that existed for their own life. Decision-making was distributed through interactions with social and material actors that occurred over time and place. I think we came into London in about September, and I had a first round of coughing during winter for about 2 months, but I didn't have the symptoms of TB. It was just a long cough, I guess. Then in spring, I think, yeah, end of spring, the cough started and it came with sweating at night, and I started getting very tired. I thought it was because I was working for so much for so long. I felt that I just ran out of energy. And so you can see that over time, these sensations are building up, and that is contributing to this decision around whether or not there is something that needs to be done within the body. Another person that I interviewed, Rose, used the internet to help her describe how urgently she needed to act when she coughed up blood. And again, that's another example of how decision-making is distributed, not just within your own self across time, but with information provided from other sources. And in the end, Jason, who I interviewed there, and by the way, these are all pseudonyms, was pushed into the action by concerns from his brother. Now, people also described having to overcome priorities. This is from an interview with Imran, who is an undocumented migrant. So you also said you didn't go to the doctor for a while because you had a cough. Yes, I had a cough. I didn't have time to go as my job timings were such that I thought, how will I go? How will I not go? When it got worse, then I thought, no, that's it. I have to go. Then I went. These priorities, Jason was too busy, and similarly, Imran did not want to lose out on being at work. Jason said there was no life outside the studio, and despite his progressing symptoms, he continued to, quote, work and ignore it, work and ignore it. Widely critiqued for, this is Maslow's hierarchy of need, and although it's been widely critiqued for its assumption that one cannot achieve self-actualization without first fulfilling the criteria lower in the pyramid, my analysis shows that nevertheless, while more complex and specific to each individual, participants did prioritize accessing healthcare in the context of other competing needs in their lives. For those who had challenges to their safety, didn't have a place to shelter, or lacked financial capital, particularly the undocumented migrants I interviewed, like Imran above, or those who were homeless like Stefan, health was often deprioritized until it affected their ability to manage these other needs. So we come to the point of doing something. Quote, he is a friend of my friend. My friend who lives with me works as an electrician, does many other things as well. My friend knew him from before and helped him to prepare the clinic and became his friend. When he saw me bleeding, he phoned him and told him to bring me to his clinic. So he was the friend of this doctor. I knew him. Ahmed was a North African man who was diagnosed with pulmonary TB. He was an undocumented migrant having overstayed his visa. the clinic he speaks of here is French speaking and does not ask for your papers. So at work here, we can see the importance of social capital and its interaction with Ahmed's identity as an undocumented migrant. In another excerpt, he also describes fear. There are also, and I've alluded to some of them here, material actors of access. You know, distance to the clinic becomes important in relation to your ability to get there. Opening times become important in relation to what your job is. Physical accessibility in relation to the abilities that you have, linguistic accessibility and social capital. But there are also policies and laws at local, regional and national level. And I've alluded to this fear for undocumented migrants that they had. And this was all occurring in the context of the British hostile environments. Going to move on to illness identity, which I spoke about in the early slides that that Walter's model introduced. And illness identity is something that was suggested as a way of extending candidacy by Sarah McDonald and colleagues in their study, which looked at help seeking and access to care in cancer versus heart disease. The quote up here is, slowly, slowly, something was happening to me. I described tuberculosis as an insidious illness. Sergiu, one of my participants, had presented to multiple healthcare providers over the course of months and had been given 2 courses of antibiotics prior to being referred for a chest x-ray. Guidance suggests an x-ray should be performed on individuals who have had a cough for 3 weeks or longer. By the time of presentation, Sergiu's cough had gone on far longer. He describes then feeling panicked when his candidacy is finally ratified through an abnormal test. I was at work, so I'd done the x-ray Monday, and then I was at work Thursday morning, and I got a call around 10 o'clock, and the doctor said that the x-ray came, and they were a bit strange, and how far did I work from the hospital? And I was starting to get panicked, because the tone was like, oh, this is strange. How far do you live? I was like, if you want, I can come right now. There's no problem. I don't have to wait. Okay, come right now. I just left the work, and because I didn't know about TB, I was thinking about something worse, like maybe cancer, or what could there be? But then I found it's TB, and I was even more confused. I didn't know what was going on. It's unclear a little whether Sergiu's panic was a product of the caller's tone or the urgency implied by the question, quote, how far do you live? Urgency was most apparent in the cases of people I interviewed with pulmonary TB, and perhaps suggests a split illness identity. Pulmonary TB as a public health threat, extrapulmonary TB as not. And this shapes participants' experiences of healthcare access. TB is life-threatening for both types of TB if left untreated, and harm to individuals is greater the longer treatment is delayed. However, the emphasis in policy on early diagnosis is arguably largely related to its position as public health threat, with time to treatment only available in Public Health England reports for pulmonary cases. Similarly, as an infectious threat, TB is exempt from NHS charging regulations, even for individuals who are ineligible for free NHS care. And this inscribes an albeit limited form of what Didier Fassin talks about in terms of bio-legitimacy on the bodies who carry TB, infectious or not. I say limited because, as I will show, limited because other health conditions are chargeable. And so if you present with TB, but also have diabetes, you might be charged for your diabetes care, but not for your TB. And that indicates that ineligible lives are only worth caring for when not doing so threatens the lives of the eligible British public. So once you have identified yourself as a candidate for care and you've determined to do something, you need to present somewhere. Were you anxious about registering with a GP? I don't want to go back to my country. No, don't go. This is, by the way, an interesting example of how your interpreter can shape your interview. No, don't go. They say, participant, they say that if you want to register with the GP, you have to have a passport. That was an interview with Ahmed, who is an undocumented migrant with pulmonary TB. Although suggested in the original model of candidacy, Mackenzie and colleagues underscore the importance of examining the role of multiple candidacies. An individual can hold multiple, potentially competing and conflicting identifiers which affect their determination of candidacy for healthcare. So, for example, a migrant who suspects they have TB might also be a parent and wish to protect their child, but at the same time fear engaging with government institutions for fear of deportation. I suggest that multiple candidacies might be more broadly conceived of as multiple identities. Being a candidate for healthcare is one aspect of an individual's identity, an identity that, as Nera Yuval-Davis describes, is always becoming, always in transition. And alongside Mackenzie's description of conflicting or competing candidacies, I would add the idea that different characteristics might intersect such that they enhance or depress notions of candidacy in ways which overlap and are interdependent. And that's been described using terms like triple jeopardy, quadruple jeopardy, multiple vulnerability, or multiple stigma. But actually, I think really reflects the idea originally established in feminist theory and termed intersectionality, that identifiers of disadvantage should not be considered in isolation. Once you have presented, then a health professional needs perhaps to adjudicate. So he, the A&E doctor, had seen someone in Majors. I think it was someone who was not accessing the GP for, I think, a headache, a chronic headache, so pretty innocuous. This is an interview with a nurse, by the way. Not A&E type thing, but they presented at a pretty quiet time because they were failing to access care anywhere else. And he had gone to see them and he was telling me about him. Oh, you know, he came in with a 3-month history of a headache and his GP wasn't seeing. And I was like, oh yeah, I mean, yeah, it sounds like he's struggling. And then he was like, and then I found, and then he said he's an asylum seeker. And then I thought, well, I just can't be bothered then. So adjudications for whether or not someone is entitled to healthcare might be moral, as in here, technical, as in related to whether or not perhaps their X-ray shows changes, or social. In relation to adjudications, concordance, a study of access to primary mental health services in the UK added concordance to the concept of candidacy. Concordance is the requirement for both service provider and service user to acknowledge candidacy. Stevenson and Scambler argue, quote, trust may be seen as a necessary basis of concordance, and that concordance between users and providers is pivotal to move towards enabling health needs to be fulfilled. But I suggest the concept of concordance already exists within the candidacy framework as the unachieved outcome of adjudications by healthcare professionals. And as such, it's already included in the framework and doesn't need to be an extension. However, I think it might be fruitful to interrogate how concordance and consequently trust as its fundamental building block is constructed, given its pivotal position at the boundary between adjudications by professionals and then their offers of care. So in terms of offers and refusals of care, I interviewed an overseas visitor manager. Quote, but what they had said at that time was that they would rather die than go to hospital and have their child lumped with a bill, the adult child lumped with a bill, because they knew it was going to affect their life in the UK afterwards. So there are many reasons why people might be offered care and then refuse it. And I think that to enable for someone to have their healthcare needs fulfilled, we need to understand better how these negotiations take place, and then why offers of care are refused, because there are hidden reasons often, like this one, which is unlikely to come up in a consultation, particularly, just referring back to the previous slide, if trust isn't there between a healthcare provider and the patient. I mentioned recursivity before. Recursivity describes how future demand for services and the process of help seeking is determined by a patient's previous experience. And I think that this is a really important aspect of healthcare access that is overlooked. Participants in my study described a multitude of interactions they defined as, quote, good and, quote, bad when accessing healthcare. These often implicitly and on occasion explicitly shaped health-seeking behaviour. Rose, for example, had not changed her GP once since arriving in the UK, despite moving to a different London borough. She spoke about how she had a really good relationship with her GP, that he was, quote, approachable and didn't make you feel, quote, like, oh, you're coming to see the doctor and it's quite scary, quote, showing perhaps the influence previous healthcare encounters had had on her decisions to seek healthcare. For an insidious condition like TB, where diagnosis is constructed over time, place, and person, I would argue that recursivity plays a greater role than other more acute conditions. You are likely to present multiple times before you get to your diagnosis, and therefore there's ever increasing opportunity to be deterred because of an interaction you've had. Kavandis and colleagues suggest extending the original framework of candidacy to include recursivity as well as concordance. In doing so, they and others imply Dixon-Woods and colleagues' original construct did not take care of it. However, I would contest that the 7 phases of candidacy that I showed you in that step-by-step approach before are described as overlapping and dynamic. And throughout each phase, there's the opportunity for candidacy to evolve, be renegotiated or diminish, depending on influences at, quote, material, structural, organizational, professional, social, cultural, and individual levels. However, I think that because it's such a vital component of healthcare, we should name recursivity and draw attention to it, as others have done. Hierarchical systems. So in addition to recursivity, McKenzie et al. Suggests that candidacies are negotiated within hierarchical systems. And they use the example of the prevalence of a higher socioeconomic group within higher education institutes and suggest that this is divergent from non-market dominated health systems like the NHS. Although they qualify this judgment as perhaps being applicable only to the NHS prior to the Health and Social Care Act of 2012, so interesting how perhaps these changes have increased the hierarchical nature of the NHS. I would caution an assumption that power differentials are at the basis of why hierarchical systems influence candidacy. Power is pervasive and exerted in and through ever-changing ways and means. It is also exerted simply by encouraging people to act in a way that aligns with imposed normative values. That's what, as Foucault has described. So, for example, as noted by one participant in Good and colleagues studies, NHS campaigns such as those aimed at dissuading inappropriate use of A&E may have differential effects on negotiations of candidacy across different populations. And I think that kind of probably speaks to each of us intuitively. You know, some people really don't want to use healthcare, and so if you tell them, you know, think twice before using A&E, they're going to think twice at a different position from someone who doesn't have any problem with accessing healthcare. Presenting to A&E rather than going to a GP for TB has been shown to expedite diagnosis. And so again, these campaigns might have an impact on how TB is diagnosed. And furthermore, while entry into the NHS at some point is mandatory to obtain a diagnosis of TB, other systems of health provision exist within the UK. And as such, attention should be paid to how hierarchical systems affect the negotiation of candidacy, and vice versa, how performance of candidacy comes to perpetuate or challenge these hierarchies, even within a system that professes to provide equitable access for care. Finally, I want to talk about these operating conditions, heeding the macro. This is an article by Claire Fogues, who writes, I think currently for, continues to write opinion pieces for the Times, put feckless patients at the back of the NHS queue, drawing on these neoliberal ideas of individual responsibility. And this is one of the go home vans which went around East London around the time of my research and before, around the peak of the TB epidemic, encouraging people to report anyone living in the UK illegally, and was part of the British hostile environment policies. I've stated that healthcare access is a relational process, and as such it is necessarily subject to power relations. And in particular, these relations occur between multiple actors, with regulation ranging from governing of the self to governing of others. Lemp has argued that it is not possible to study the technologies of power without an analysis of the political rationality underpinning them. And Foucault describes governmentality as the, quote, conduire des conduire, the conduct of conducts, or better put, I think, by Birchall, the regulation of behavior, or the art of governing, gouvernementalité. Governmentality facilitates a study of the integral link between micro and macro political levels, valuable to my exploration of the conditions or milieu that shape individuals' experiences of healthcare access. Healthcare access provides a space within which a direct link between the state and the state's practices and mode of governing comes into contact with individuals. And given governmentality allows for an analysis of that integral link between micro and macro political levels, and has the potential to reveal the rationalities that govern how candidacy is constructed, both upwards from the self and downwards from the state, and I'm drawing on Foucault here, bring both theories to bear on my data, has added a novel and critical perspective to the study of healthcare access. And I refer to these rationalities or operating conditions as milieu in the way that Foucault has done. Foucault defines milieu as a certain number of combined overall effects bearing on all who live in it, which govern the conditions of possibility when it comes to the construction of someone's else's candidacy for healthcare. So these socio-political milieu in my data were reflected perhaps as patriarchal societies. In one interview, Saida told me that she couldn't register with a GP because her husband had all of the bank details in her name, and she needed some sort of proof of address, and she couldn't provide it. Austerity, neoliberal capitalism also were present in patients' narratives, shaping their lived experiences, and on occasion more explicitly impacting the construction of candidacy. Rose spoke about a failed asylum seeker with mental health issues who she'd been trying to get support for, and said charities have a lot to deal with at the moment, so it'll be hard for you to get to the right support at this time. Basically implying the impact of austerity on service provisions. So I'm not going to go into more detail here. I'm going to finish up just with my final suggestion of how I think candidacy should change. So here I want to draw together my analysis of participants' experiences and the literature that I've reviewed. I contested the negation of power in describing negotiations as made jointly. As a relational social process, candidacy is necessarily subject to power relations, although power imbalance does not necessarily impede access to or quality of healthcare. I was also concerned with the limitation of the adjudicating participant being conceived of as either a health professional or envisaged as a physical space. Rather, participants' experiences show that candidacy is co-constructed and shaped by interactions with health professionals and other actors, material and social, that constitute this, what I would call the broader healthcare arena. I dismiss others' critique that the original outline of candidacy did not emphasize recursivity, as a property. Nonetheless, I replaced dynamic with recursive to underline the infinite possibilities and diachronic nature of interactions involving healthcare access and the important role that these play in the often long-term attempts to have one's health needs fulfilled. I then introduced the idea that the construction of candidacy is distributed across space and time, evolving through multiple interactions. Drawing on Rapley here, I described candidacy as distributed to draw attention to the multiplicity of interactions and actors that construct an individual's eligibility for care. And this shift is reflected in a broader change in focus away from individual making rational decisions towards a more relational autonomy. I broadened the context within which these interactions occur, foregrounding the influence of social constructs that shape experience, but not forgetting the influence of physical surroundings, themselves manifestations of societal structures that nevertheless are experienced in their materiality. In considering the influence of social environment, I include the regimes of truth and normalizing practices that govern how and what we know, incorporating but expanding on the original emphasis on the role of typifications used by staff to categorize people and diseases, and thinking about, for example, the patriarchy or biomedicine. In relation to how policy imperatives act to construct candidacy, I consider policy to both interact with individuals as material actants, thinking about Latour, and as a discourse shaping particular operating conditions. In addition, I avoid suggesting the level at which these environments are defined or act, moving away from singling out local pressures, which arguably shifts focus away from larger scale determinants of candidacy towards a definition that can encompass each of the micro, meso, and macro spheres of influence. And finally, I incorporate intersectionality as an analytic device to explore the ways in which the identities of interacting actors shape candidacy. As with the infinite ways in which candidacy comes to be defined and redefined through interactions, there are infinite ways in which individuals can be stratified in society. Drawing from Yuval Davis's analysis of intersectionality, I draw attention to the infinite ways in which people can be stratified. As she argues, this is not to obscure the fact that in specific historical situations and in relation to the daily lives of specific people, there are some social divisions which are more important than others. So in a patriarchal society, we might think of gender as being really important, but in a society that's predominantly racist but might not be so patriarchal, then race might be the defining issue. Not to say that they're not coexisting. The addition of an intersectional perspective to candidacy, as Yuval Davis summarizes, facilitates a recognition of the social power axes rather than of social identities per se. I want to end just with this poem. I alluded to the issue of doing research in a different language, and I think that this poem beautifully illustrates how that is can be very challenging and influences the ways in which people can express themselves. And so as a parting note, I encourage all of you who are doing research across languages to really think about that in your grant applications to ensure that it's properly funded. Thank you very much to everyone, and thanks very much for inviting me, and to all the participants who took part in my research.
Jess, thank you. That was a tour de force, I think, in terms of taking us through much of that, and your insightful and thoughtful critique of candidacy, which obviously is a theoretical framework that several of us have used as well to try and understand our work around healthcare access. I can open this to questions. If people want to post questions in the Q&A, I don't know if anyone can come in and actually override the mute to ask their question, but if they can, feel free to do that. Also, the problem with the Q&A is you've got to wait for a moment for people to type their question. But while people are kind of thinking about that and coming to sort of think about their questions. I thought one of the things that, as you were talking, Jess, and it sort of reminded me of some of the discussions that we've had, although candidacy isn't necessarily presented as or thought of as linear, it is this kind of repeating patterns. We tend to still focus on people identifying first and then sort of moving through. What comes from your work that might help us think about where people might enter that candidacy journey at a different point? So, you know, particularly with something like TB, is it coming in for other reasons that then gets them to start identifying and seeing themselves as a patient with TB?
Yeah, so I think with TB, there is a national screening programme for people not born in the UK for latent TB infection, which is asymptomatic. And so if you were invited to take part in screening and then you're identified as potentially having signs of active TB, then you might be further investigated, and that you might then not have identified yourself as the candidate for care. So we have identified you. And how that changes one's experience, and particularly I think the adjudications and the offers and resistance of care, I suspect will be different than if you've identified your own need. You know, we often asking people to take tablets for prevention rather than cure, and we know that that is more challenging than asking you to take treatment for curing something that you're suffering with. And I think the same principle probably is at play there.
Okay. And with your large number of interviews that you did, obviously with people who were diagnosed with TB, you also have that different sort of, some were students, some were undocumented migrants, etc. So I guess that sort of wider policy environment is quite different for different people. How is that impacting on their journey?
Yeah, it's interesting. I was certainly critiqued for when I was designing the research for choosing such a broad category as people not born in the UK. What did they share in common that made it reasonable for you to conduct a study about their shared experiences? And my argument to that was that society that we're living in at the moment is broadly xenophobic, and that there exists both policies and behaviours that position migrants and people who are racialised as foreign as other. And I was interested in their what experience, if any, they shared, and whether and their experience more broadly. And that's really what led me to these broader macro conditions that shape how people, you know, all aspects of people's messy pathways to getting the healthcare that they need.
Yes, I think messy pathways is a good way of thinking about it. Do we have other questions? Anyone else wanting to pose? Let's pick up one. I've got one here. So about can outreach programs increase services utilisation and access, particularly think about particular groups? Thank you.
It's a really good question. I think in my experience, yes, because if you're thinking about how people identify themselves as a candidate for healthcare, and then the conditions which might impede them from accessing it. So, for example, the Find and Treat service is a great example of this in relation to TB. They're big vans that go to hostels that screen people for active TB, because active TB is much more common amongst that population. Also takes away some of the barriers for people accessing healthcare who are street homeless by coming to a central location, perhaps somewhere where they get food, and removing the barrier to, should I need to think about where I'm sleeping tonight, where my next food is, and just being present there. So and similarly with outreach organisations, that the local migrant support groups that I work with, who are there to inform people of their rights, to try and encourage a trust between them and the health service, to help people navigate pathways. If you move, I interviewed lots of people who were moving from India to the UK. So I did an ethnography of a pre-entry TB screening centre, and many of those people knew something about the health system because they had contacts here, but those people who didn't had no idea about how the health system works here. And there's no point during their journey at which they're provided with any of that education. Now, how do you find a GP? It's actually very easy. Just Google find a GP, and it comes up, you put your postcode in, and then you've got a selection. But how are you supposed to know that if you've never lived here before? Much like if I was moving to another country, I wouldn't know what I was supposed to do in various different circumstances. So absolutely, I think there are lots of different roles, and thinking about the social determinants of health. So people are not going to think about going, registering with a GP to get vaccinated if they don't have a roof over their head or a job. And so it's supporting people in those other things to allow them to prioritize their health.
Yeah, absolutely. And I guess it's many of those things we've seen writ large during the pandemic as well, and really coming home to roost in terms of some of those challenges.
I guess
Sorry, on you go.
I was just going to say, I guess one of my questions I have almost for myself is how I take this very complex, messy understanding of healthcare access and apply it, how to improve the access to healthcare for my patients. And there are certain ways in which you can easily incorporate it into your everyday practice. So if you think about recursivity and how important your interaction is, each and every interaction you have with patients, about how they're going to come back in future, but also how angry patients might be angry because they've been treated badly before, and that can allow us to have a little bit more compassion when in the face of dealing with people who are perhaps not treating us as we would like to be treated, or who are resisting the offers of treatment in ways that we don't expect. And so I think that thinking like this, with this complexity, can change the way that you practice on an individual level, at least. How we do it on a grander scale, I need to think more about.
Yeah. No, I think that's very true.
And in fact, David's asked that question, so maybe I've answered but not answered it, David.
Yes, and we've got a final question from Sarah McDonald about how has the impact of COVID messaging impacted in candidacy, and thinking about protecting the NHS and what the long-term implications of that might be in terms of recursivity.
Really interesting. I think this whole notion of protecting the NHS, so starting off prior to the pandemic with protect A&E, go somewhere else. We then had protect the NHS, don't come here because you might get sick, plus we're dealing with a pandemic. And now you've got protect the NHS, don't come here because we're overwhelmed, because we don't have enough resource. I think all of these messages are really problematic. They act as barriers to people. And if you think through candidacy and how many things you have to overcome to actually ask for help when you need it, it assumes that people are just going on a whim. And I just think that is so far from the case vast majority of the time, that we should be avoiding this type of messaging at all. The other thing that has come up through my work with advocacy organisations is that this idea that vaccination for all, so we're encouraging everyone to get vaccinated, that we're encouraging everyone to access healthcare who should need it, even though there's a hostile environment, because otherwise you might be a public health threat. And that is a really problematic narrative from my perspective, that positions people who are already othered in society as only valuable in their position as a threat to people deserving. Neera Davis uses the word autochthonic, meaning the population who is supposed to be here, originally here, in inverted commas.
Yes, indeed. I think that takes us to a whole new set of areas and issues to think of. And I'm conscious that it's just past 2, so I think we should wind up. Jess, I'd just like to thank you again very much for your talk and for all the thoughts it's firing off, I think, for many of us. It's great pieces of work, and also really playing into advocacy roles as well. So lots there for us to acknowledge. If we were all together, we would be giving you a big round of applause. So to give you a virtual round of applause.
Thank you.
And say thank you again, and hopefully we will meet at some point, maybe later this year, who knows.
Yeah, excellent.
So, thanks for your time.
You're welcome.
Bye.
Thanks everyone for listening. Bye.